right, guys, we're back. Sorry about that. Trying to work through some technical difficulties. Okay, perfect. So we're back. We're running through some technical difficulties, guys, but we're going to keep moving on with more questions that we have. For the next question, for someone unsure about reconstruction, is it possible to have reconstruction later if they're unsatisfied being flat?
Good. Okay, so the question is the timing of reconstruction, and can you delay your reconstruction until, for whatever reason, whatever personal reasons? Yes, the answer is yes, and delayed reconstruction can be accomplished really at any point down the road from the mastectomy. Dr. Pisano just gave a nice answer about why autologous reconstruction or tissue reconstruction gives a more sensate breast, a warm living tissue. That can be done at any point down the road. It can be done in as early as, say, 3 months, 6 months, 9 months, or many patients I'll encounter that they're 5 years or even 10 years out from a mastectomy and can have a tissue reconstruction. In the same sense, implant reconstruction can be done later, but that involves a tissue expansion process, and generally 2-stage, where the skin is stretched and then a permanent implant is placed. So the disadvantage to that is the stretching of the skin and the placement of a foreign body. But yes, it can be done later down the road, and that will give patients time to plan accordingly. Now, I might mention too that it's in our practice, we feel that if the patient's a proper candidate, doing it all at once and doing the reconstruction at the time of mastectomy often gives a superior result, because the skin can be spared and the breast shape can be more easily reconstructed.
Is an ICU stay required after surgery?
I'll take that one. An ICU stay is typically not required. I don't remember the last time we've had a patient that required an ICU stay. Even after a long surgery, the surgeries that we're doing, the tissue reconstructions are sometimes lengthy, 6 hours, 8 hours sometimes. We have a great team of anesthesiologists that make sure that fluids are administered appropriately, not too much, not too little, just the right amount of fluids. So typically it's not necessary an ICU stay. We have a dedicated wing at the hospital that we primarily work at that is staffed by breast nurses that typically help with the recovery process in the postoperative period. They're highly trained. They know exactly what to look for. If they have any questions, they know how to get a hold of us quickly. So having them is a tremendous resource, not only to help us monitor the patient postoperatively, but also there's just a tremendous wealth of information for the patients to access immediately when they're recovering. So no, ICU stay is not required in our practice when we do these even very complicated tissue reconstructions.
Someone wanted us to go back to the Aeros protocol because they weren't able to hear that earlier. Can we go over the Aeros protocol again?
Sure. The question is about the Aeros protocol. Dr. Ochoa gave a little explanation of that a few minutes ago, but just to recap, the Aeros protocol is a plan of management that starts before surgery, and then some things are done in the operation, and then some things are done after. So it's kind of a 3-part approach. It begins before surgery with a nutritional drink that we use to keep the gut working, the bowels working. There was a day and time not too long ago when patients were kept from eating or drinking for long periods of time. And we've learned that this prolongs recovery, not just from the kind of surgery we do, but many other types as well. So we keep the gut functioning by having patients take a carbohydrate drink. It's basically like a sports drink. And then we use a collection of medicines, non-steroidal anti-inflammatory medicines. Those would be things like Celebrex or Aleve or Motrin, one of those, in combination with Tylenol. And then during the operation, we inject in key areas in the trunk and the chest a long-acting numbing medicine that lasts 5 or 6 days. It's a medicine called Exparel is the trade name. And then afterwards, we continue that collection of medicines, the Tylenol, the non-steroidal anti-inflammatory, and by and large, narcotics are not required anymore. And we've learned that, in general, narcotics, while they control discomfort, prolong recovery from surgery. Again, not just the type of surgery we do, but all kinds of surgery. So we've almost eliminated narcotics now, but through the rare instance of breakthrough pain. The other thing that we do is rapidly mobilize patients. We get patients moving very, very early the day after surgery. It's almost sometimes the same day of surgery in essence, because it can be just several hours after the operation ends. Whereas in the past, we kept patients at bed rest, and we've learned that prolonged bed rest is not good. So these are some things that we do that have really cut down on the length of time of the hospital stay and then overall recovery. So when I began in this practice in 1994, patients from the DIEP procedure stayed in the hospital between 5 and 7 days, and most patients stayed closer to 7 days. Now patients go home on day 2, and we had a patient recently go home on day 1, which means it can be done. So this is a sea change in the recovery process.
And we want to encourage everyone, if you have questions you want us to answer, go ahead and put them in the comments. Another question we got was, what is the recovery time for flap surgery? Like the ability to pick up your children or exercise after surgery?
Okay, so I'll take that one. Typically, we talk about a 4 to 6 week recovery time, but oftentimes we can extend that to 6 to 8 weeks if there's heavy lifting involved, if the patient is baggage handler or someone who works for FedEx or someone we want to have a longer period of recovery before you're lifting heavy objects. But typically I like to break that down a little finer and talk about what happens week by week. The first week, we encourage everyone to have a family member, significant other, or caregiver with you 24/7, because just the process of getting up and the process of taking care of activities of daily living, washing, going to the bathroom, and so forth, really requires someone there 24/7. So for the first week, that's the intensive period. But again, as Dr. Pisano pointed out, there shouldn't be a lot of pain involved. There's going to be some postoperative discomfort, but really that's a function of just recovering from surgery. That second to third week is when you're going to come in for visits. You may have to have a driver to remove a drain. You're going to have to be changing garments. You're going to be needing help with showering, cooking, and so forth. So no lifting at that point. And then that 3 to 6 week time frame is where I gradually get the patient involved in more activity, working on their shoulder motion, moving their arms, bringing their arms above their head, able to do your hair, doing more walking. As Dr. Pisano said, you're walking right from day 1, but we don't encourage patients to be doing long walks. We start with shorter walks. And then the process of picking up children we can introduce at that point for little children, infants, 3 to 6 weeks, but we don't want any introduction of back to your heavy lifting or squatting or doing workouts and so forth until 6 weeks to 8 weeks. And then as we reintroduce patients who are very active and they want to work out and so forth, we have to realize that surgery does involve some alteration of the abdominal wall, the skin, and the muscles. And although we preserve the abdominal muscles, we still do stretch them in harvesting flaps. So we want to gradually increase over a period of about 4 weeks to ramp up to heavier exercise. So I hope that answers the question, in sort of more detail than just 4 to 6 weeks.
Definitely. Can we discuss nerve reconstruction? Who's a candidate for nerve reconstruction? How is it done?
Sure, I'll go ahead and answer that. Nerve reconstruction is something that we are always trying to do on every single patient. It's something that we discuss with the patients during our preoperative appointment. When we are taking the tissue from the abdomen, part of that is finding the small blood vessels that are providing blood flow to the skin and fatty tissue. We're also looking for the nerves that are providing sensation to that part of the body in the normal setting. When we find those nerves, we go ahead and separate those nerves, dissect them to the point that we have enough length of those nerves. So once we transfer the skin, fatty tissue, blood vessels, we also transfer the nerves all together into the mastectomy and chest area. So after we connect the blood vessels, the arteries and the vein, then we find the nerves that are providing sensation to the breast in normal situation, and reconnect those to the nerves that we just harvested with the tissue flap. There's sometimes we find nerves, sometimes we don't find nerves. So we can't definitively say on each individual patient that we are going to do the nerve reconstruction. It's just if we find it, we'll do it. If we don't find it, obviously we cannot do it. In terms of recovery of sensation, that's probably the question that would follow this particular question is, how long would it take for that sensation to start to be evident? It can take anywhere between 6 months to a year to regain sensation of the breast once we do the nerve connections. So it may take a while for that to fully manifest itself.
Can you explain why some patients require expanders and others don't?
Sure. The question is, why do some patients require a tissue expander and others not, or don't require a tissue expander? So generally we'd be talking about an implant reconstruction. So usually a tissue expander is required in the setting of a delayed reconstruction, meaning the mastectomy has been done and the skin and soft tissues that remain after the mastectomy are sitting down against the chest wall and usually very tight against the chest wall. So in order to accommodate an implant, the skin has to be stretched back to form stretched out to form a pocket. So the tissue expander is an implant filled with saline or sterile salt water, and we put that in. And usually when we put it in, we fill it part way, and then there will be a series of office visits during which time we add a little of volume each time and fill the expander to get the skin nicely stretched out. Then at a second operation, the expander is removed and the implant is placed. You may not need an expander if the reconstruction is done immediately. So in other words, if the implant is going to be placed at the time of a mastectomy, when the overall envelope of the skin that covers the breast is still out to length, then an implant or a piece of tissue, either from the abdomen or the thigh or wherever, could be put in place right away without the need for expansion.
Okay. And then if someone is choosing to do a lumpectomy or breast conservation, what are their options to improve symmetry?
So if someone is choosing a what we call a lumpectomy, or the medical term more definitively is called partial mastectomy. In general, those patients are not going to come for full reconstruction, for breast reconstruction. So to improve symmetry, we often may do surgery on the opposite side. The breast that undergoes breast conservation surgery is usually a little bit smaller once the partial mastectomy is done, not only because the oncologic surgeon is going to be removing a portion of the breast, but also because that requires radiation to be given after the partial mastectomy. So the radiation is managed by a second medical professional called a radiation oncologist, and that will shrink the breast a little bit. And so you should discuss that with your radiation oncologist. Depends on the dose that's given and how it's given. So women with a larger breast may choose to undergo with us called an oncoplastic procedure. If the tumor is in an area that can be removed safely and the remaining breast can be reduced, that would be a breast reduction, and the breast can be preserved, but the radiation will still need to be given. And we would discuss as your plastic surgery team what would be done with the opposite side to improve symmetry. That could include a breast reduction, it could include a breast lift, also could include a breast augmentation, either with an implant or with fat grafting. So everybody is unique in this regard, and it needs to be discussed in detail for each particular person.
When radiated and flat, can DIEP still be done?
I assume this is following mastectomy?
Yeah.
Yes, absolutely. And in fact, it's probably the preferred way of doing reconstruction in situations like that. So when a mastectomy is done, the excess skin is removed and the incision is closed achieving a flat chest. If radiation is still required in that situation, if the patient was diagnosed at the locally advanced stage of breast cancer, where radiation would still be necessary not only for a large cancer but also for involved lymph nodes, the remaining breast skin or chest skin at that point becomes very dense and fibrotic because of the radiation changes. So in that situation, if a patient were to come to our practice and seek reconstruction, a tissue expander placement in that situation would be very difficult to do, because that remaining skin is much stiffer, doesn't have the elasticity anymore. So expanding that skin would be very, very difficult and a high complication rate. The expander can be exposed during the expansion process. The expander can become infected, and requiring us to remove it. So in situations like that, the ideal method of reconstructing the breast would be using the patient's own tissue. Because of the large need for skin, which was removed with the mastectomy and also worsened by the radiation, having a large amount of skin to recreate that skin envelope is extremely important. And out of all the donor sites, meaning all the areas in the body that we can take tissue from, the abdomen is typically the one that we can obtain the largest amount of skin to compensate for that loss of skin that they've experienced with the mastectomy and radiation. So yes, not only is it possible, it is the preferred way of doing it.
If in that sense, if someone is not a candidate for DIEP flap but they don't want implants, what are their options?
The question is, if somebody is seeking a reconstruction and they don't want an implant, and they're not a candidate for the DIEP flap or the DIEP flap, what are the other options? Let me begin by saying the overwhelming majority of patients that we encounter in this practice are candidates for the DIEP flap. As Dr. Nastala mentioned early in this forum, the DIEP flap is the preferred way that we do reconstruction, and the overwhelming majority of patients, that's what we do. But On rare occasions, somebody might not be a candidate for DIEP flap. Why? Well, owing to previous surgery, and usually it's gynecologic surgery or childbirth, cesarean sections, or a combination of those things. So a typical patient might be the person who's had several 2 or 3 C-sections and then maybe had a hysterectomy, all done through the quote bikini approach, which layers on lots of scar tissue. And I would add as a footnote, this is getting less likely in the sense that a lot of gynecologic surgeries now done robotically or laparoscopically now, especially robotically. So we're seeing fewer of the open hysterectomy incisions like we once did. Secondly, in order to rule in or out the DIEP flap, we would get a study called a CT angiogram. So many people have had CT scans. You're in the donut-shaped scanner, and some dye is given intravenously, and we create a map of the blood vessels to the lower abdomen. So the CT angiogram can tell us whether a person is a candidate or not with a pretty high degree of certainty. In the instance where a person's not a candidate, there's been blockage of the blood vessels that we depend upon on the DIEP flap. There are many other areas of the body to go to, including the thigh, the inner thigh, kind of upper outer thigh, and back of the thigh, upper kind of backside of the thigh, and then the trunk, so the buttock area, and then finally the upper trunk for the chest. So I'm going to say there's 5 or 6 or 7. There's also one from the kind of the outer thigh, kind of the saddlebag area. So 5 or 6 or 7 other options that we fall back on.
We had a question. When you have cording caused by radiation after a lumpectomy, what is the process used for reconstruction? This woman has been told that she's not a candidate for implants due to scarring.
So cording is something that we see fairly frequently in patients post surgery, especially if they have some axillary surgery, the axilla being the area under the armpit where the lymph nodes are. So lymph nodes are little specialized organs of tissue that are involved in our immune system, and they're all connected to each other by a series of network of channels called lymphatics, which are very thin walled vessels, and they transfer fluid, mostly fluid and cells. So cording is something that's typically seen in women that have implant reconstruction and axillary surgery, and also maybe radiation. All these processes sort of dry out, so to speak, or cause the channels to get blocked. And so when a woman lifts her arm, she'll see cords in the axilla or cords coming from the lower part of the implant. The question was, what can be done about that, and are you a candidate for reconstruction? Well, the first thing that we do for cording is get involved with our physical therapy colleagues, and specifically we refer to groups who are highly specialized in physical therapy related to cancer patients. One group headed by Rachel Larson is called Forte Physical Therapy, and Forte specializes in releasing those cords, and probably a large percentage of the time those cords can be broken up physically with different means that they have: ultrasound, massage, stretching, heat therapy, etc., and that's done on an individual basis. Another option for those is surgical release, and then we do have a lymphatic program headed by Dr. Garza, Ramon Garza III, who does various diagnostic procedures to see if those lymphatic channels can be restored. I don't think cords in and of themselves would be a contraindication to do reconstruction, but again, you'd have to discuss that with your doctor to see if they can be released. And autologous tissue reconstruction, the DIEP flap and other forms of reconstruction can often potentially improve that type of cording or scarring or lymphatic blockage.
And speaking of Rachel Larson, we did highlight her with our virtual booth today, so all of her information is on our website. You can go back and see the interview we did with her if you were interested in getting in touch with Forte and get the information to reach out to her. With today being Breast Reconstruction Day, what is the significance, in your opinion, of breast reconstruction education?
I'll take this one. The significance of the education. Well, I think it's extremely important to get this information out to everyone that is involved or has family members, friends with breast cancer, to give them the ability to think about what is available out there, determine whether it would be something that they would be interested in pursuing. In terms of what are the benefits of breast reconstruction, there's been multiple studies that have looked at the psychosocial benefits of breast reconstruction. How do you see yourself in social situations? And breast reconstruction clearly has demonstrated that it improves the patient's overall outlook by having breast reconstruction. Now, every patient doesn't necessarily benefit from breast reconstruction. There's some women that choose not to have breast reconstruction and feel completely complete, so it's not everybody's the same. But for the majority of women, having that part of their body removed can be extremely impactful and have significant negative effects on their overall, sense of well-being. So breast reconstruction and all the other and all the risks and benefits of each procedure, I think, are something that requires sort of a deliberate discussion with someone like a plastic surgeon or reconstructive surgeon that can go over those things with the patients and determine which one would be best for them. Now, Dr. Pisano alluded to having a shared decision-making process, which basically what that means is talking with the patients, discussing this with not only the reconstructive surgeons, but also the breast oncologists to determine what is the best way to approach the diagnosis of breast cancer in their particular case. We know from studies that women that have an involvement in the decision-making process tend to be more satisfied with whatever surgical treatment they choose to have. There are ongoing studies that look at, does basically the knowledge, the preoperative knowledge of the risks and benefits of reconstruction, do those translate into higher or better psychosocial well-being, better sort of patient-reported outcomes, and that's something that we are interested in investigating a little bit further also. But what is the benefit of education for breast reconstruction? I think it's multifaceted. I think that patients have a much better and clearer picture of what we can offer, what is available out there, and that can be, I think, affect patients positively once they do have reconstruction, as them feeling like they had a part in their treatment.
Right. It looks like we're winding down. I just have a few more coming in. If you guys have any other questions, keep coming in. If we don't get to it tonight, we will get to it in the comments. We will keep on here all night and respond through the comments. What does breast reconstruction increase the risk of breast cancer returning? The DIEP flap, having the DIEP flap. Want to take that one?
I can take that. That's a great question and a commonly asked question, and also a misconception. So the short answer is no. Having a breast reconstruction in and of itself does not increase the likelihood of a recurrence of breast cancer. The likelihood of a recurrence of breast cancer has to do with the characteristics of the breast cancer that one presents with. The size of the tumor, whether lymph nodes are involved, the grade of the tumor, certain of the tumor markers that the pathologist will study. So that collection of things creates a staging system that then becomes a predictor for recurrence. You might ask after a mastectomy, why would there be a recurrence in the first place? And that's because the dividing line between the skin over the breast and the thin layer of fatty tissue or subcutaneous tissue, the technical term, and the actual breast tissue itself is not a smooth dividing line like it is, say, in the thigh between the skin and fat and the covering of the muscle underneath. That's a well-defined border. In the breast, that's not the case. So when a mastectomy is done, little rests of breast tissue, some of which can't be seen with the naked eye, may remain under the skin, and that could give rise to a recurrence later on. Or the recurrence may come in the form of disease in the area Dr. Nastala just talked about, the underarm area, the axilla, the lymph nodes. And finally, a recurrence could come back as a metastatic process in another organ, say the liver or something like that. But breast reconstruction in and of itself does not increase the risk of a recurrence.
Can fat grafting alone be used for reconstruction?
That's a good question. So fat grafting, yes, in certain circumstances can be used alone. That requires a very labor-intensive process and multiple stages, but in some doctors' hands that can be done. I think you'll find that most of that type of reconstruction is done in Europe, where the doctors have a particular center that specializes in that. I don't think that's very common in the United States. Because fat grafting is very different. In a sense, what we do with the DIEP flap is a fat graft, but it's a fat flap. Flap meaning the flap is transferred with its blood supply reconnected to the breast. So when we say flap versus graft, the flap has to be reconnected and restored to its original blood supply. A graft takes its blood supply from the region where we transfer it. So if you had a burn and you had a skin graft from your thigh to here, that graft would have to achieve its own blood supply on the new site. So the fat graft is done by harvesting fat through a modified liposuction technique. We liposuction an area where the patient would have some extra fat, for example, in the saddlebag area or the flank. And then that's processed just like we do normal liposuction, but with a very, very different, delicate, modified technique in which the suction pressure is much lower. The cannulas, meaning that where we remove the fat, are much different. And the system is a closed system in which the fat is kept healthy. That fat is then put into small syringes and injected in a process which doesn't subject it to a lot of pressure to burst the fat cells. So that fat can only be injected in relatively small amounts. So if you think about just reconstructing a breast with fat grafting, you can imagine that you wouldn't be able to put in enough fat to restore a full breast. So just thinking about it in that sense, you can do a little bit at a time with fat grafting. So fat grafting is used in many of our second stage operations to fill in minor defects, to enhance certain areas, or to restore some softness and suppleness in areas that are irradiated. So it's a great adjunctive technique, but it's not currently used commonly to do a full breast reconstruction.
Awesome. And the final question we have for the night is, who's a candidate for nipple-sparing mastectomies?
I'll go ahead and take that one. The candidacy for nipple-sparing mastectomy is primarily dependent on the location of the tumor, the known lesion, in relation to the nipple areolar complex. Probably the most conservative and accepted method used is distance, is 2 centimeters. If it's within 2 centimeters, then the nipple, it's advised that the nipple would be removed at the time of mastectomy. If within 2 centimeters. That is usually ascertained by using an MRI, magnetic resonance imaging, to determine how close this lesion is to the nipple areolar complex. Certainly, if the patient is very attached to their nipples and they want to keep them, a mastectomy can be done using the nipple-sparing technique, and a section, a small sliver of tissue can be removed from underneath the nipple areolar complex, send that to the pathologist, and have them take a look at it intraoperatively to determine if there's any abnormalities of those cells within that specimen. If there's any signs of any atypia, any sort of or any sort of malignancy, obviously the nipple has to be removed. So from an oncologic standpoint, that would, whether the nipple can be spared or not, that would be solely determined by the proximity and ultimately at the discretion of the surgeon, of the breast surgeon. In terms of, from a cosmetic standpoint, could a nipple-sparing mastectomy could it be performed? That's all dependent on the skin quality as well as the position of the nipple and areolar complex. Let's say someone has, for example, a genetic mutation, BRCA, for example, and they have no cancer within their breast, but have had a number of children and have had, let's say, massive weight loss where their nipples are in a very low position. Could that patient have a nipple-sparing mastectomy? Certainly from an oncologic standpoint, there's no reason why the nipple has to be removed because it's a prophylactic mastectomy. However, from a cosmetic standpoint, it may be quite risky to leave the nipple in place because of the lack of blood flow to that area. So those are the things that we would have to sort of consider: the skin quality, the position of the nipple. There are newer techniques that we're using here at PRMA where even in a nipple that is malpositioned in a sort of what we call a caudal malposition, where it's a little bit lower than what we would expect, we can still do nipple-sparing mastectomy in those situations, and at the stage 2, go ahead and do a lift and keeping that nipple directly attached to the flap that was used for the reconstruction. That technique is something that we've been using probably for the last couple of years, and we've achieved really, really good outcomes using that technique. Even though it's a little bit more, it's a little bit riskier, we haven't had any particular problems using that technique. So it sort of expanded, using that technique, it sort of expanded our indications for nipple-sparing mastectomy.
All right. Well, we want to thank you guys all for spending your night with us. And thank everyone online for all their questions. It's been a great virtual bra day. First for a virtual bra day. Again, if you guys have any further questions, go ahead and just leave them in the comment box. We'll be on there most of the night answering them. If we don't get to it tonight, we'll talk to you tomorrow. Thank you.
Bye. Thank you.
All right.
All right. Good. Well, that was good. That was good. That really, other than the
We pulled it off.